Assess the bowel and bladder. Anatomy of the posterior cul-de-sac. The posterior cul-de-sac, PCDS, also known as the pouch of Douglas, POD, or recto-uterine space, is the space between the rectum and the uterus. It is an extension of the peritoneal cavity and is lined with peritoneum. In a normal pelvis, this space is a common location to see a small amount of fluid. Normal physiological fluid can be anechoic or have some low-level echoes. When free fluid is present in this area and there is a positive sliding sign posterior to the uterus, it can be said that the posterior cul-de-sac is not obliterated. Posterior cul-de-sac obliteration occurs due to the formation of adhesions between the posterior aspect of the uterus and the surrounding structures. This results in a negative sliding sign. Fluid in the posterior cul-de-sac can help with the assessment of endometriosis. There may be strands of tissue which can be seen extending from the peritoneum into the fluid. With the motion of the probe, these strands may be seen to move in the fluid. This may be referred to as the jiggle sign. The term loculated fluid collection indicates that fluid is contained within an area of adhesions. The fluid in a loculated fluid collection may be of a different echogenicity than surrounding fluid in the pelvis. The rectum. Normal rectal wall layers can be visualized on transvaginal ultrasound. The serosa and surrounding fat are hyperechoic. The muscularis propria is hypoechoic. The submucosa is hyperechoic, and the mucosa is hypoechoic. The lumen of the bowel often contains hyperechoic contents. As the vaginal transducer is inserted, it is possible to assess the anal sphincter and the rectum. Slowly insert the probe while angling posteriorly in the sagittal plane. Follow this section as far as possible by angling posteriorly until the probe is positioned at the top of the vagina in the posterior fornix behind the cervix. While advancing the probe in the sagittal plane, sweep from side to side to assess the entire posterior wall of the vagina, the anterior rectum, and the rectovaginal septum. After investigating the rectum in the sagittal plane, rotate 90 degrees and sweep through the area again, as some portions of the anterior rectal wall may be easier to delineate in transverse. The rectum should generally follow a path behind the vagina, cervix, and the uterus until turning to the patient's left at the rectosigmoid colon and traveling superiorly to the left ovary. It may be difficult to see the sigmoid colon, but while assessing the left ovary for sliding sign, you may inadvertently obtain information about the sigmoid colon. Endometriosis of the bowel wall. Bowel endometriosis causes smooth muscle hyperplasia and fibrosis, resulting in thickening of the bowel wall and potential narrowing of the bowel lumen. The bowel may have a pulled appearance. It may be tightly curved or C-shaped, or have a spiculated or moose antler appearance. There may be a thickened hypoechoic segment which may be adherent to surrounding structures such as the ovaries, uterus, vagina, and/or the uterosacral ligaments. All lesions should be interrogated with color or power Doppler using a low PRF to show slow flow. When measuring the affected segment of bowel, find the longest length of thickened wall. This is usually seen as a sagittal length on the bowel of the affected area. Place calipers on each end of the area, including all of the thickened hypoechoic area up to the normal thin bowel wall. On the same image, place calipers perpendicular to the first set, at the thickest point of the hypoechoic area to measure the thickness. Rotate the probe 90 degrees to sit transversely on the bowel, to view a round cross-section and sweep through the affected area in this orientation. Find the widest point of the hypoechoic thickening of the wall and place calipers on each end of the area. Include all of the thickened hypoechoic area up to the normal thin bowel wall. There may be more than one area of endometriosis on the rectum and sigmoid colon, so follow as far as possible to determine if there is more extensive disease and measure each region in the same way. Each area of endometriosis should be imaged and annotated with the anatomical region. Even if you are unsure of the exact segment of bowel you're looking at, it is still helpful to label known structures on the images. The key is to find the lesion and describe the location and appearance so that it can be assessed more thoroughly by an endometriosis expert. The anterior cul-de-sac. The anterior cul-de-sac, ACDS, is the potential space between the uterus and the bladder. It is an extension of the peritoneal cavity and is lined with peritoneum. When performing the sliding sign maneuver, apply pressure in the anterior fornix, just superior and anterior to the cervix. It should be possible to see motion of the bladder serosa versus the anterior aspect of the uterus. The anterior cul-de-sac may contain free fluid. Endometriosis and adhesions can occur between the anterior aspect of the uterus and the posterior bladder wall. This results in a negative sliding sign. A partly filled bladder will help to assess the bladder wall and delineate any possible lesions. If a lesion is seen, document the area with images showing measurements in 3 dimensions and Doppler flow within the nodule and surrounding tissues. Site-specific tenderness. During the acquisition of images and while performing the sliding sign, it is important to document patient discomfort. If the patient is experiencing pain or tenderness in a specific area, it can be documented with the acronym SST, short for Site-Specific Tenderness, on a representative image. This will allow for easier reporting at the end of the scan when you're documenting site-specific tenderness on the technical impression or final report. If the patient has overall pelvic tenderness or is very sensitive in most areas of the pelvis, this does not need to be documented multiple times but can be described as diffuse pelvic tenderness in the report.